So good evening, friends. On behalf of Bangalore Intensive Care team, we welcome you all to the sixth, the monthly PROCON debate. And today we have two sessions are there. And the first session is about, the balanced crystalloids. We have an excellent speakers are there. Our moderator is, Dr. Randomized Chatterjee. He's a CMO in charge of intensive care services, intensive care emergency services at Swami Dayanand Hospital, Delhi. And he has been given an excellent, discussion in one of the last sessions about, one of the debates here. We all know him. And we have the speakers today for the topic. The first topic is about, the statement is like, the balanced crystalloids are fancy solutions. So person who is going to be pro for that or supporting that statement, that telling that it's only a fancy solution, is Dr. Jojo Kurian John. He's a senior consultant in intensive care from Kochi Medical Trust Hospital. And against that, Dr. Pooja Murthy, consultant in intensive care hospital, Manipal hospitals will be making the contradictory, arguments against the statement. And I request Dr. Randomized Chatterjee to take the session forward.
Thank you, Dr. Ajit, and thank you, Dr. Pradeep, to give me another opportunity to interact with you in such a grueling debating session that you are conducting. Really, the debates are of international quality, very high-level quality debates, and the excellent speakers will prove that right. And we are going to speak on a subject where we are basically using this crystalloids, the fluids, since 190 years since now, IV crystalloids. When it was started by way back in 1832 by the person, even his photo you will not find. You will not found anywhere. Started it after in Birmingham, and still now after 190 years we are debating which fluids to be given, whether it is a crystalloids or colloids, and in crystalloid which one is a balanced salt solution or our traditional normal saline. So let us see how Dr. Kurian John proves that the balanced salt solution are fancy fluids, and how Dr. Pooja disagrees with him and say no, it is the choice today, and let us set aside our traditional fluids like normal saline. So I pass on the debate to Dr. Kurian John, and I ask him to please stick yourself to time for within 15 minutes. Dr. John, please.
Thank you, Dr. Ranajit, for the kind introduction. So, am I audible and visible?
Yes.
Yes.
Okay, so I'm here to argue that balanced crystalloids are only fancy solutions. And before I go into the science of it, I would like to first define what fancy is. So I asked a lot of people what fancy means to you, and I got a lot of responses. So generally it all boiled down to a few things which I summarized here. Fancy stuff is more exclusive, it's costly, there is a lot of attention given to the packaging and presentation and the style. Some amount of promotion is always involved. Heroes, icons, etc. are seen using it and promoting it. There is usually some added subjective elements which may or may not be of value depending on your particular preferences. And in general, these things are okay for a while, but not for regular use. That's the common definition that I get. And I can assume that most of you would get on board with that definition. And just to give you an instance, a 10 rupee coffee that you buy on a railway platform would be your regular coffee, where as it gets fancier, as you go from say Sarabanavan, where it costs around $35, to Starbucks, where it costs $250, and to a toxic level of being fancy, the most expensive coffee in the world, Kopi Luwak. So this is definitely fancy. So if you look at normal saline, mineral lactate, and plasma light, the solutions that we are considering, a normal saline, the cost today, according to Google, is 27, and mineral lactate costs about 1.5 times that, and plasma light about 5 times that. And you can see as the price increases, so does the packaging and being the sexy look of the product as such. So I have established that indeed the balanced solutions are fancy. The rest of my talk is going to concentrate on whether they are only fancy or they have something add-on. Let's get right to it. The entire history of development of fluids, as Dr. Renajit referred to, has been checkered by a lot of controversies. For instance, we had the landmark reverse trial, the EGDT, which was sort of the guidance which actually told us about fluid resuscitation for decades altogether. And it required 3 big international RCTs and a meta-analysis to prove that some of those things are wrong, which cannot be duplicated. And still, the Surviving Sepsis campaign advocates big fluid boluses, which has been proven to be harmful and killing patients. We have the entire saga of colloids, the very expensive toxins, which we actually made our patients buy and actually got harmed. We all know about the scientific misconduct and papers, especially Joachim Boll's paper, which had to be retracted. So in all this, what we see is that there is a big involvement of pharma. Most of the trials that we see have some element of pharma support, and we have to take that into account when we are interpreting the data. And even though per bottle the cost isn't that much, the market of intravenous fluids is huge, running to thousands of millions of US dollars in the America alone. Let's not forget that. There has been a consistent level of, can I say, demonization of normal saline by internationally acclaimed speakers, calling it abnormal saline, non-physiological saline. And at the same time, we have had a very aggressive promotion of the so-called balanced solution. They have used very seductive phrases like balanced, physiological, neutral. So let's look at saline. We have been using saline for ages, like 2 centuries, as has been said in the introduction. It's easily available, cheap, and compatible with many of the drugs that we use in the ICU. What are the issues with it? The issues are nothing that we don't know about. Saline contains more chloride and more sodium than is there in plasma. And if you give a lot of it, you will produce hypernatremia, you can produce hypochloremia. That we know. And the real concern, or rather the only concern here, is that the hypochloremia can sometimes produce a reduction in GFR. The freely filtered chloride, which goes to the distal convoluted tubule, the macula densa senses the chloride which is delivered, and if it is high, it produces what is called a tubular-glomerular reflex to produce a reflex reduction in the glomerular filtration. So high chloride can potentially reduce your GFR. That is a concern which we all have been aware of. There is also some concern about splanchnic hypoperfusion and coagulation abnormalities, which are frankly actually related to the speed with which we give fluid and a dilution of the plasma proteins. And it is true of all IV fluids, not of saline alone. So yes, saline does produce hypochloremia, and the hypochloremia produces a hypochloremic acidosis. But how harmful is it? Is it really harmful? Let us look at the evidence. Till this decade, till the last 2 years, we have had these 4 trials which looked at it in a randomized control fashion. The split trial by Paul Yanks was the first trial. They looked at it and they found that there was no difference in acute kidney injury at the end, but the numbers were not that good. And then after that, we had these 3 American studies. And of this, only the SMART trial showed a change in the renal adverse effect. This was not a renal failure. When they measured each renal outcome per se, they did not find an effect. But when they took a composite outcome called the MAKE 30, there was a significant adverse effect of the regarding the renal function. Let us look a little bit in detail regarding the SMART trial. This was not a multicentric trial. In contrast to what many people would say, even in the meta-analysis, this was a single-center trial. It was unblinded, and they say it is randomized. But do you know how it was randomized? If you go to the ICU in January, you get ringer lactate. If you go in February, you get normal saline. That is not randomization. I would not call this a randomized control trial. Granted, let us say how they came to that outcome of renal failure. If you look at any of the renal outcome, the need for renal replacement therapy, a percentage of people who actually had a doubling of creatinine, the death due to renal failure or the total death per se, none of them were significant. And when they made this composite outcome of MAKE 30, again on first analysis, it did not show a statistical significance. And then they had to do an adjusted analysis, and then they found a p-value slightly less than 0.05. And the fragility index of this is 0.1, which means that if you add just one patient on either side of the arm with a different outcome, your p-value will become insignificant. So the SMART trial really was not that smart. So there was a controversy, but because there was a hint of harm because of renal failure, which was shown due to normal saline, many of the societies and guidelines started suggesting using balanced solution for resuscitation, including the sepsis guidelines. But fortunately, now we have 2 big, well-conducted, multicentric, randomized controlled trials, which have looked at it. Let's look at them one by one. The basic trial conducted in 75 ICUs in Brazil, very well conducted trial, very well randomized, very well blinded. The initial patient population well representative of our ICUs. 2 arms, plasma light and saline, and primary outcome of mortality, no difference. Renal failure, no difference. The only difference was in patients who had cerebral edema or acute brain injury. The plasma light killed them. This is the subgroup analysis. You can see that there is no difference between the 2 groups, all of them closing the line of unity, except in traumatic brain injury, where plasma light plainly killed them and normal saline was better. The next study, the PLUS trial, conducted in New Zealand and Australia. They aimed for 8,000 odd patients. They had to stop with 5,000 odd patients because of COVID. No difference in outcome. The mortality was same. The renal failure was same. They did demonstrate that in the saline group, the chloride levels were high and the pH was low. It was very well shown. They got enough of saline to show that the chloride went up, but even when the chloride went up, you could see the creatinine did not, and the renal failure did not, and the need for renal replacement therapy did not. So based on these 2 also, we have a new meta-analysis which is published in NEJM Experimental, looked at all the trials with less bias, and you can see the combined risk ratio is 0.96 with confidence interval 0.9, crossing over the unity to 1.01. And if you look at this, starting from 2014 to 2021, you can see, if you look at the median of the forest plot, you can see it's coming slowly towards the unity line, 0.82 coming to 0.92, then 0.99. If you do a major trial again, I'm sure it will come to 1, definitely showing that there is no difference. So as Paracelsus said, it is the dose that makes the poison. If you give normal saline with your in the normal way that we do, measuring the patient's values and adjusting to it, it does not harm at all, at least in terms of renal failure or related outcomes. And there are certain situations in which there is no other option but normal saline. In a situation where there is a cerebral edema, you have to use something which is normotonic, and the only available solution now for that is normal saline. How about cirrhotics? Solutions with lactate has a problem because we use lactase as an index of the liver function. Although we do not have an evidence that lactate per se is harmful, we keep a view on the lactate to see how the liver function is deteriorating. And more importantly, we have many intensivists and trainees who will give a fluid seeing the high lactate if that lactate is not cleared, because despite a lot of data, that is still a reflex that happens in ICU, and there is a higher chance of over-resuscitation in this group. Hyperkalemia is a conundrum because the classical teaching earlier was to avoid ringer lactate in hyperkalemia, but after the split and SMART trials, which showed that hyperkalemia was rather more in the normal saline group compared to the ringer lactate group, it has sort of changed. But what is important to remember is that the hyperkalemia, when you give lots of fluids, like 5 to 6 liters, like in a kidney transplant patient, that hyperkalemia is secondary to hyperchloremia, which is expected, which is anticipated, which produces a shift in potassium to keep the electroneutrality. Whereas in patients who have oliguric renal failure, they are directly dependent on the sodium delivery to the distal tubules. And if you give a hypotonic fluid like lingeractate or plasma light, it can actually potentially reduce the renal clearance of the potassium and worsen the hyperkalemia. I'm not the person who is telling that. This is from the Association of American Society of Nephrologists in the article published in 2022. How about drug compatibility? There are lots of drugs which are not compatible in the balanced solutions. Ceftriaxone, ciprofloxacin, diazepam, ketamine, lorazepam, nitroglycerin, phenytoin, propofol, blood components. So typically in the PLUS trial, many people who were in the plasma-light group got additional saline. Why? Because all these drugs had to be given in saline. So summing up, you have balanced solutions which are expensive, well packaged, and there is some subjective element. They are physiologically more neutral. However, there is no evidence, strictly scientifically speaking, that normal saline produces any harm or is inferior to any of these. And in terms of cost, we have an advantage. I like fancy stuff too once in a while, but for fancy patients, for fancy situations, not for all patients all the time. Thank you.
Thank you, Dr. Khoury and John. Very well presented. And I think you have taken exactly 15.5 minutes to present your case. Well, let us see how Dr. Pooja responds to it. And then we will come to a rebuttal, and after that, a conclusion to the. Dr. Pooja, please. Please go.
I'll just share my screen. A very good evening to everyone. I would like to thank the Bangalore Intensive Care Group and ACME for providing me the opportunity to talk here. Let's go to the topic quickly. I think Dr. John, let's see how balanced crystalloids are not only fancy solutions. I think I don't want to bore you by arguing or by just giving evidences against the whole thing. But I want to tell you an interesting story about IV fluids. I think we are all interested in IV fluids. Let's hear a story now. We have evolved as humans. We have to evolve. And we all know that we used to give blood transfusions, colloids. Unfortunately, we are stuck in the Stone Age with normal saline. But I think we need to move forward with balanced crystalloids. And even further more so, the era in the future will be PHET guided resuscitation. So the story, unfortunately, should not go backwards, but it should go forwards. But how did this all begin? Like Dr. Chatterjee already told us, it all began almost 200 years ago with the cholera epidemic. And this is Dr. Thomas Latta, who developed a primitive saltwater solution to be injected into the veins of patients who were losing fluids in the bowel. And thus the story began. But are we stuck there? Is normal saline really normal as it is said? Where did the term come from? It came from a Dutch scientist called Hamburger, who unfortunately considered the concentration of salt in the body to be 0.9%, which is not truly so. It is a historical fallacy is what I can say. It's actually 0.6%. And he also wrongly argued that equal concentration of a solute in a solution is to be considered normal. I don't know how do we take that. Has this topic been reviewed? Yes. In 2008, by Sharif Awad, reviewed the history of normal saline, and he concluded that there was either no physiological nor evidence-based rationale, and our current practice of using normal saline is just based on historical misconception. And the story happily went on for more than 1.5 centuries. And in 1980s, the questions and people started questioning what are the problems with normal saline. There, our story came to a new twist. There was a twist in the tale where the villain was not sodium, it was not normal saline, but it was chloride, where a paper by Wilcox in 1983 showed that there was increased vasoconstriction of the renal vessels and decreased GFR with chloride. Then the hidden story came out. A lot of ill effects of chloride came to the picture. There was increased vasoconstriction, there was oxygen unloading, kidney injury, GI disturbance, acidosis, the list goes on. And one thing we should not forget as intensivists is that up to 45% of our ICU patients have hyperchloremia, and it is up to 75% of patients in the first 24 hours have hyperchloremia. But is hyperchloremic metabolic acidosis naive as argued by Dr. John? Does it cause harm? Does it not cause harm? What we can see is all our patients, especially in the Indian scenario, are very sick, are acidotic either because of sepsis, because of shock, because of hemorrhagic shock, and adding an acid-rich solution where the pH of normal saline is just 5.5 to it will definitely not cause it to become alkalotic, is it not? That's a simple logic there. And balanced crystalloids being an alkalotic solution definitely, or at least, will not cause harm. So let us understand further into it. One thing which all of you want to understand is the strong ion difference and the Stewart's approach here. This is the difference between strong cations and strong anions, and the normal value is around 42. Whenever there is an increase in chloride, there's a decrease in strong ion difference, and this adds to metabolic acidosis. As we can see here, any increase in chloride will lead to acidosis, and the acidosis is not just naive. It is not, since it is normal gap, it doesn't mean there is no acidosis. The acidosis is true, and it is there to stay. Coming to balanced crystalloids, why are they called balanced? It is not a fancy term. The balanced term is because there are two most important things that balances the solution. One is the strong ion difference is close to that of the value of bicarbonate, which is between 24 to 29. And these solutions also have a low chloride content. And as we have understood, any increase in SID, which is more than bicarb, will lead to alkalosis, and decrease in SID, that if it is less than bicarb values, will lead to acidosis. What is the SID of normal chloride? It is 0. So it is extremely acidotic, and we cannot infuse acid into a patient, is it not? These are different values of the various balanced crystalloids, and most of them fall into the range of bicarb concentration. Plasma light is definitely having a higher SID, and it's an alkalotic solution. Is only hyperchloremic metabolic acidosis the problem? No. Hyperkalemia, vasodilation, hemodynamic instability, inflammation, renal injury, mortality, the list just goes on. To give a few evidence regarding this, there have been various experimental animal experiments as well as human studies that have happened. Kellum in 2004 showed in animal studies of septic animals that there was a mortality when normal saline was used, and mainly chloride was blamed at. It also caused vasodilation. Hyperkalemia, is it safe? We argued, and Dr. John himself agrees that hyperchloremic metabolic acidosis leads to hyperkalemia. But can we ignore that hyperkalemia just because it is caused by a solution? No, we cannot. This definitely can cause harm, which is again proven by various papers. A randomized trial in patients with renal transplant showed that use of normal saline caused more frequent episodes of hyperkalemia in them. Just not hyperkalemia, but also shock, hemorrhagic shock. Can we use it as a fluid of choice? May not be. Again, animal experiments by Martini et al. Showed that even though there was no difference in mean arterial pressure, but the amount of fluid that was needed was significant when normal saline was used. And we are in the era where we are talking about fluid restrictive strategies. And why do you want to use high volumes just because you have a choice to use normal saline? We should not. Many other studies, including perioperative complications, were higher in patients in whom saline was used. In septic models of sheep, it was shown that there was increased vasodilation, increased hypotension, which was shown by various studies, and the list goes on. I think the number of papers are huge on this. Not only that, inflammation. A paper by Wu et al. In 2011 showed that increased inflammation in patients with pancreatitis. To this, the American College of Gastroenterology in 2013 changed their guidelines and added ringer lactate as a fluid of choice for resuscitation in the initial phase of pancreatitis, which is again proven by another paper which showed increased in C-reactive proteins. So not inflammation, not vasodilation, then acute kidney injury, yeah, rat models, healthy volunteers, and critically ill patients. All of them have shown to have a worsening acute kidney injury when sodium chloride was used as compared to that of balanced crystalloids. So these were all animal studies. We may argue these were all single center trials, but we are in the era of large RCTs. So let us go to that. Coming to the split trial, in 2015, it was a double-blinded cluster randomized trial in New Zealand. 2,000 odd patients were used, which did not show any mortality difference. Did not show any difference in acute kidney injury at 90 days, nor there were difference in secondary outcomes. How is this proving all the previous evidence which was shown to be wrong? Let's see. Maybe let us analyze the split study even better. First thing is, it was just a feasibility study where there was no sample size calculation at all, and about 8% of patients were missed from the outcome analysis. More so, majority of the patients were from post-operative cardiothoracic or vascular surgery, and only 15% of patients were admitted directly from emergency department, which does not match our cohort of patients at all. We are looking at sicker patients. We are looking at patients who've come from in sepsis and rest of the patients. And another thing in this study is about 1/3 of the patients also received buffered crystalloid even in the normal saline group. This was before they got admitted into ICU. So this definitely has diluted the outcome. Then came the SMART study. It was a large study, even though it was a single center study, it was a large study comprising of around 15,000 patients. And this just did not show the incidence of acute kidney injury, but it also showed a composite outcome of MAKE 30. This showed that the major adverse kidney events were significantly higher in the saline group. The risk of death was significantly higher at hospital discharge or day 30, and the need for renal replacement therapy was higher. So this effect was more pronounced in patients with sepsis. But why is it so? Mortality is not just because of kidney injury. Mortality is because of the other harmful effects of chloride, that is inflammation, vasodilation, more so in septic patients. So it just not causing acute kidney injury doesn't rule out the other effects or other harms that are caused by hyperchloremic fluids. So definitely SMART analysis cannot be ignored. Then came the SALTED trial, which again showed there was a significant increase in stage 2 acute kidney injury and also MAKE 30. This was also in around 2018. Then there were two large trials which was done in the last couple of years. One was the BASICS trial, which was done in Brazilian ICUs. But we should always get our basics right, and it just not doing a big study doesn't mean that it is true. One thing is they had wrongly calculated the power. They had calculated to have a mortality of 35, but where the actual mortality was 27% only. Why is it so? Because the acuity of patients were not very sick. The Apache score was only around 12 and so far 4, as against, I think, at least in Manipal, we see the average Apache to be at least more than 15 to 18. Again, 50% of them were elective post-op surgical patients, which was not again coming from the emergency department. And 68% of patients also received another fluid. And among that, 30% of them received a balanced crystalloid even in the normal saline group. So we have to view that again with a pinch of salt. Then came the PLUS study in this 2022. This definitely was a very well conducted study, but once again here, The admissions from emergency were very less. Again, most of them were elective post-op surgical patients. And a median of 625 ml of saline was used even in the multi-electrolyte group. So there is no clear-cut randomization and clear-cut adherence to the fluid of choice which we are comparing. And that is where it is. And this was subsequently followed by a meta-analysis. This was by Naomi Hamad. And let us try to dwell this in a little detail. Again, they tried to answer the same question. Should we use balanced salt solutions or saline? And 90-day outcome. They chose 6 studies. 3 of them included the most recent studies, Basics Plus and SCOPA, and a large number of patients, around 34,000 of them were involved. This was what the overall outcome was, even though we say the odds ratio or risk ratio is around 0.96. What we have to understand is they also did something called a sensitivity analysis, and it was extremely high certainty that there was a 8 to 9% decrease in mortality versus 1% increase. And also, they also considered the Bayesian meta-analysis for sensitivity and showed that 89.53% risk reduction in mortality was there when balanced crystalloids was used against normal saline. So how do we summarize this study? There was a relatively 9% relative risk reduction as against 1% increase, and definitely 89.5% of them had decreased 90-day mortality. So we have to analyze this. Of course, I agree with Dr. John that patients with traumatic brain injury, maybe saline is better, but rest of the patients are common patients with sepsis. We don't know. So definitely this meta-analysis concluded that balanced crystalloids are safer and better in patients, especially in the subgroup of sepsis and who've been on dialysis. So do you still believe balanced crystalloids are fancy solutions? Let's come back to our story. The story began with the historical fallacy that normal saline is not normal. The hero of disillusion, that sodium chloride, was replaced by a new villain, chloride. There is enough physiological evidence, experimental evidence that the harm done by sodium chloride came up, included the list which we already saw. The powers of the villain became very clear. Split trial tried to split the story, tried to confuse us, but smart viewers are definitely not fooled, and I'm sure you're not fooled. Basics, of course, we always have to get a basics right, and we have to view the study with whatever background statistical flaws. Plus, has tried to add to the confusion, but definitely the final meta-analysis clearly shows who the real hero is. The real hero is definitely balanced crystalloid. I think Dr. John spoke more so about the cost. Is it expensive? I was definitely worried about it. I thought it is really expensive, but when I just called my ICU to ask what the cost is, I just had to take a foot back. 500 ml, these are real-time pictures which were shot today by me in the ICU. 500 ml of RL costs 59 rupees or 58.58, whereas 500 ml of normal saline costs 79 rupees. So who is fancy now? Is it RL or NS? I think you can definitely guess it. Even though if say NS was equi-cost or it was of a lesser cost, who will pay for the cost of dialysis? Who will pay for the cost of life? To conclude, normal saline is hypertonic, acidotic. There's no physiological rationale. Significant adverse effects, I think the list we have already gone through. And definitely no cost benefit either. So it does not fancy at all. It is really a rational solution to be used. And do you still want to use the abnormal saline? Just because we can use it, just because it's cheap, just because that's how I was trained to use, or it's just because the nurse just starts normal saline. I don't care which solution. So I urge you to get smart. Let's join the smart club and stop using the abnormal saline. Thank you so much.
Excellent, Dr. Pooja. Very well rebutted, and exactly have taken the same time as that of Dr. Kurian. Dr. Kurian, you want to rebut? You want to say something about
please.
this? Yes.
Yes, please.
Should I stop sharing the screen?
Yes, please.
Yeah. And you have 5 minutes time, Dr. Kurian. If you want, you can use 5 minutes, or if you can use less, but 5 minutes.
Okay,
The time starts now.
Dr. Pooja. So let me first start with the cost of my slide is not moving. Okay, let me first start with the cost, Dr. Pooja. If you're paying more money for normal saline than renal lactate, either you're being cheated or the Manipal hospital is taking both you and your patients for a ride. Let me come to the analysis. You can clearly see, I mean, instead of looking at the conclusion, if you look at the data, you can clearly see that it is crossing the line of unity. And the relative risk is 0.96. I agree, which means that some patients are benefited, some patients are harmed, which normally, when we analyze statistics, we take it as having no major effect. And how did they come to the conclusion of saying that in 85% it is beneficial? They did one analysis, the p-value was not good enough. So what they do, they did multiple analysis, again not good enough. And finally, with a Bayesian meta-analysis, they could get a small significant effect. And then they said, okay, this is a benefit. Do I believe it? Normally, that is not how we do science. You have a null hypothesis, and if your primary analysis intention to treat does not show that, then my belief is that it shows that either further studies need to be done or your hypothesis is wrong. With 35,000 patients done in an RCT, I cannot imagine that you can do an RCT better than the PLUS trial or the BASICS trial, pragmatically. So I do not think it is really logical for us to ask for more trials. So this is what is called p-hacking. What can you say when your p is less than 0.05? A trend towards significance, approach borderline significance, blah, 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 blah. And now the latest fashion is the Bayesian analysis, which I leave it to the audience whether to take it or not. When you are biased, you tend to believe in your bias. And when you love something, it is very difficult for you to say that it is not true. So they said the estimated effect of using the balanced crystalloid versus saline ranges from 9% relative reduction to 1% relative increase. To me, it means it really does not make much of a difference. Coming to the clinical trial versus real world evidence. I'd just like to show you then the NICE guidelines in UK after the SMART trial and the surviving sepsis guidelines actually mandated that people use balanced crystalloids. And then they did an analysis between 2007 and 2017 to see how the practice changed and how the incidence of renal failure, if any, worsened. And the use of normal saline had tremendously come down after that guideline change. And the primary outcome, which was acute renal injury, actually increased. I agree that there was no hypothesis. This was not the agreed question. But the real world where we treat, as you suggested, that our patients may not be exactly the same as in BASICS trial. They got more surgical patients, more patients from ED, or Apache was less and all. But these are factors which you cannot control. But this is real world data, and it seems to suggest that there is no difference. And the logic that you suggest, being physiologically neutral, having a good SID, they are all fine. I like that logic. But when we do this critical care numerology, trying to correct numbers, it does not work. We aim normal PO2 in ARDS, normal PCO2 in ARDS? No. We do not like to bring it to the normal levels because we now know that despite some animal studies, when you do it in humans, it actually kills them. And we have even more dramatic examples. Glutamine in sepsis. There was a lot of blah, blah, blah. Glutamine levels are low. You correct it, people magically become better. Vitamin C. Again, the evidence is not there. And as scientists, we believe the evidence. When 35,000 people have been randomized and there is no evidence, I want to believe that. So I would try to close by saying that we have to make the important measurable and not just the measurable important. And when we balance, we have to balance a lot of things like the evidence, the cost, the patient condition. We don't blindly give food to the patients. We don't say all my patients get normal saline in this month and plasma in the next month. We actually measure their chloride, don't we? If it is chloride, we can always change it. We measure their pH. If they are acidotic, we can change it. We actually manage the fluid according to the patient's data. And the drug compatibility is a big issue, which again accounts why the PLUS trial, the plasma-like group, had to be given normal saline, even though they were randomized there, because you could not give a lot of medications without using saline. On the other side, we have to always remember that big pharma influences each and every decision that you make, and you owe it to the patient to base it on science. Thank you.
Thank you, Dr. Kurian. Dr. Pooja, you want to revert?
Yeah,
Or you are satisfied with the... Yes,
no,
please.
I'll just try to revert. I mean, it's not an argument though.
All right,
Give me
please.
a minute. Yeah. So I'm not able to change my slide again. Yeah. Okay, coming to the cost, of course, I don't control Manipal and I don't control the costs in which they are. This is what we see. This is what has been there. And unfortunately, thousands of patients are being treated. And you can see here, both of them are from the same company. So it doesn't mean that we are trying to flaw it. The costs are real time. So that's one argument as per the cost, and the whole argument, in fact, about normal saline is cost and nothing else. So why are we behind to use a solution which is acidotic, which has a strong ion difference of 0, which unfortunately animal experiments are the way forward in terms of proving a significant difference as compared to, because the control is easier in them, and which has definitely proven that just not hyperchloremic acidosis, but the other ill effects is what I'm trying to tell. Hyperchloremic acidosis could be naive if we argue, but definitely it is not as naive as we want to see. See the list: hyperkalemia, vasodilation, hemodynamic instability, increased inflammation, renal injury, composite mortality, which was again studied in SMART trial. SMART trial just did not do it. And how many of our patients last for more than a month in the ICU? Hardly any, is it not? Less than maybe 1%, 2%. Most of them are just there for a few weeks. And how many of them would have got this change of solution? So in the SMART trial, the most important thing which we have to know is from the ED or from the OT, there was no mixing and matching of solutions. So it was a single solution that was followed up to the ICU for a month. And we expect most of the patients not to last for more than a month in the ICU. So the results just cannot be interpreted because there was a monthly alteration of IV fluids. That is one. Second thing is, SMART trial just did not consider AKI. SMART trial also considered a composite outcome of mortality. Of course, it was a secondary outcome, more so in sepsis, just that it adds on that chloride just doesn't cause AKI. It also causes the other ill effects, which I want to list here. This adds to mortality. And why would we want to infuse, to a layman, if I say I'm going to infuse an acid into your vein, how would that sound? So that is what exactly normal saline would sound like. Then coming to these trials, which we are talking about, the basics plus and the meta-analysis. Bayesian analysis, can we ignore it? Can we ignore how we practice every day? Can we ignore our clinical judgment? Can we ignore the subjective evidence that is there when we come to a single patient at the bedside? We cannot. So when all that is put into the picture, Bayesian analysis cannot be ignored, and whatever results we got from the meta-analysis cannot be ignored. So definitely, further studies may not prove anything more. Further studies would just add to the confusion, and I think we should be more than clear that balanced solutions are just not fancy. Balanced solutions are just not a step backward, but definitely they are a step forward. I would like to conclude that.
Thank you, Dr. Pooja and Dr. Kurian, for such an excellent debate. And both of you are quite cool and calm in explaining your sides. I really, Dr. Thomas Atkinson Latta today will be very happy to see that, yes, even after 190 years of his starting of IV fluids, we are debating still now which one to use, whether a normal saline, ringer lactate, or the other like the plasma lights or the stereofundins which are present in the market. Well, very interesting, in 2011, Dr. Louis Vincent, he came out with a paper. Can we do studies, randomized controlled trials in critically ill patients where so much of confounding factors are there, all the organ systems are involved? Can one particular thing be pinpointed that whether this is the point which is basically responsible for increased mortality or for increased renal failure or for something else? Is it possible? Because you have so many things, you have a multiple organ failure. Can only one thing, one fluid, one type of fluid can be responsible for it? So this is a question that comes in everybody's mind. And I will congratulate, first of all, Dr. Pooja, that you have not mentioned the surviving sepsis guidelines this time, where they have asked for using balanced crystalloid solutions. You could have used it in your favor. Because you have not used it, you are smart enough not to use it, because they have only used the SMART trial to prove that yes, balanced solution should be used instead of normal saline. I think these type of statements from such a big international organization coming will have a lot of effect on the whole of the intensivists working all over the world. Should we go for only a single trial? SMART trial, you are telling it's right. But SMART trial is a single center study. It's an unblinded study. The amount of fluid that they got median amount of fluid they got is hardly 1000 ml and 1120 ml. So can this fluid, with this amount of fluid, can we just pinpoint that yes, this normal saline is basically the culprit? Similarly, you are smart enough also to defend the basics trial and the plus trial. They have a lot of flaws. Most of these trials, they got around 68%, you told, I think, they got the fluid before randomization. Similarly, in plus trial also, 11% of them before randomization in the resuscitation fluid, they got the fluids. So how can you compare these things in a single? Basically, you are comparing apples and oranges, and ultimately you are saying, oh, what a beautiful mango in the meta-analysis. Comparing apples and oranges and ultimately giving a conclusion, yes, mango is the best fruit, doesn't make any sense. So on one side, I'll say that Dr. Kurian, yes, about the price, Dr. Pooja, again, you have shown a single company's price and you have only shown the ringal-lactate price along with the normal saline. If you see other companies also, normal saline in the market we get it at you should also agree with me that we'll get it at hardly at 17 to 20 rupees. And if you go for plasma light, you get at 140 rupees. There is no doubt about it. But that I am not defending that. If it is needed for the patient, 140 rupees is not a deterrent to be used in patients. I definitely agree with you. Cost should not always be a factor. When you are using antibiotics costing around 5,000 rupees, we are using a CRRT which costs you 50,000 rupees a session. Why should I think about using 144 rupees if yes, I think that it can save my kidneys? So their cost should not come into effect. Similarly, Dr. Kurian was right enough to say in defending him, yes, should normal saline, should we ban it off? You see, we have talked about the SID. It's right. Normal saline's SID is 0. Ringal-lactate, it more or less matches with the body's SID. There's a plasma SID around between 24 to 28. But the plasma light solution has an alkalotic SID of around 40 to 50. The SID is very high. It's quite alkalotic. Sometimes these alkalotic fluids are also good. For example, if we see a patient who is coming with the AKI, the creatinine rising, the chloride, we know that if more than 110, it's going up. The more it goes up, the mortality increases. It has been proved not only by a single study, but a number of studies. It has been proved. We don't have to debate on that. Yes, with a chloride level high, with a pH level going down below 7.1, with the creatinine level going up, doubling, after the initial resuscitation with normal saline, I might think of using the balanced salt solutions. We have to be balanced when you are standing by the side of the patient. That's what I think Kurian said is the last line. We have to be balanced when you stand by the side of the patient and decide which fluid has to be given, as we have to give. So in these situations where we know that normal saline might cause harm, after the initial fluid resuscitation, we might think of using the balanced salt solutions. There is no harm in it. But you know, the fallacy of where it comes, it has been seen that you have to give in a 70 kg male, if you are using normal saline of 10 liters, it decreases the SID from 40 to 32 if you give normal saline of 10 liters. If you give a round of 2 to 3 liters, it hardly decreases the SID by 2 to 3. So it doesn't make much of difference if the patients are not so acidotic. So my last word will be, conclusion will be, again a balanced one. Not in favor of normal saline or not in favor of the balanced salt solution. Normal saline is there to stay in India, not only in India, all over the world. Yes, it is going to stay. We can't just say whether it is normal, abnormal, physiological, non-physiological, it is going to stay. Ringalactate is there to stay with some of its caveats, and balanced salt solution definitely has to be used in certain situations where normal saline might cause harm to the patient. So we have to be balanced in our approach, and I thank you so much, Dr. Kurian John and Dr. Pooja Murthy, to be such a nice and courteous way of presenting the debate, and not exceeding your time limit, but keeping your points as precisely as possible. Thank you so much. Thank you. I love the debate. Thank you so much.
Thank you so much.
Over to you, Dr. Ajit. Dr. Pradeep, if you're there, over to you.
Ajit, you are muted. Ajit.
Yeah. So that's a very interesting discussion. Dr. Jojo Kurian, Jojo and Dr. Pooja has given a very interesting, arguments and counter arguments. For me also, I am a bit inconclusive in this, but I would like to admit that I have a kind of, I am just like any other person. I am also having some kind of a Bayesian bias or whatever you call, like you tend toward that. See, now, these trials, this, the so-called, the Brazilian trial, that's I presume that is that's not the SMART study, but that basic study, yeah. So basically, the basic study and all, the amount of fluid used also is much less, actually, 1 to 1.5 liters and all average. So basically, that is unlikely to make any kind of effect. If you use normal saline in that particular volume, whatever that low volume, it is unlikely to make any kind of an effect. That is very well understood, And none of the trials, whatever you call, with all the flaws around, and you see the SMART trial, you see the sorted trial, you see the basic trials, and everything is telling, most of them, telling, in favor of, most of them, there is no difference in mortality and all. Suddenly, one meta-analysis, Hammond's, the analysis, what Dr. Pooja was mentioning is, the whole thing is like an unexpected sort of judgment, suddenly, showing that, there is some kind of it is preferred is a sort of, there is a Bayesian analysis and all this just happened, actually. The confidence intervention is almost, marginally crossing, one also maybe 0.99, one of these, in general, the non-randomized studies and all. So that's a bit surprising, yeah. But I totally agree with that. At this point in time, what I can understand is if I'm going for a large amount of fluid, like, more than 3 liters or so, probably in our situation, probably it's unlikely, because I can only say that kind of a large fluid. I can only remember one patient, where cholera patient or something, we had admitted and we had to use around very huge amount of fluid. That kind of a thing, you use more than 3 liters, and obviously most of the guidelines and our restrictive strategies using those kind of things. When you're using a large amount of fluid, maybe the balanced crystalloid need to be considered. But in traumatic brain injury, as it's aptly told, obviously normal saline is preferable to even the balanced crystalloids. And obviously, maybe the future may be like, the pH-based and, the chloride-based resuscitation may be the future. So I don't have anything to add for that. Thanks for the excellent presentation, Dr. Pooja and Dr. Jojo.
Ajit, I have a point to make.
Yeah.
I think normal saline can be abnormal in normal persons, but can be normal in abnormal persons. And most of the meta-analysis that Pooja Murthy has said, meta-analysis tends to actually amplify the mistakes which the studies have already done. So in that regard, we should take the conclusions from the meta-analysis with a pinch of salt.
Absolutely, Dr. Anirban. You are right. That's what I was pointing out. Do not believe on meta-analysis. Just blindly. Use your brains.
A pinch of salt and some water makes it normal saline.
You are right, Dr. Kurian.
Pradeep, can we go to the next session? Dr. Pradeep, you want to add something? Yeah.
No, please.
So
I think it was
thanks for the excellent
discussion.
session. Yeah. Yes, Dr. Ranajit.
So, I think Ranajit has really moderated it, and I think he has put icing on the cake in moderating the session, that you may have to have balance between both these solutions. I think that's what we are practicing, honestly. So I think with that, thanks, Jojo. I think it was an excellent discussions from both Dr. Pooja and Dr. Jojo. I think we'll move to the next session. Ajit, you can take over the presentation.
Yeah. So that's it. So next, the next topic is, the evidence-based medicine. The entire intensive care community that is thriving on evidence-based medicine. For each and everything, some of the, we have a lot of, even in our among colleagues and among us, we always discuss, cross-discuss and dissect out and micro-dissection to macro-dissection. We do a lot of, we look for evidence and we try to, run the entire system on evidence of medicine. I think critical care medicine is one of the major special, as far as I know, which is thriving upon, the evidence-based thing. And, we have, one interesting statement here, that is, evidence-based medicine is, pure and it's an indisputable science. So we have, two excellent speakers for here. Dr. Srikanth Sahasrabuddhe is from Aurangabad. Dr. Sulagna, she's from AIMS, New Delhi. And they are debating about that. Dr. Srikanth is trying to say that evidence-based medicine is the pure and indisputable science, and Dr. Sulagna will be contradicting that. We have the moderator, Dr. Simant Jha. Dr. Simant is around. Dr. Simant? Dr. Simant is around. Dr. Simant?
Sir, I'm here, sir.
Yeah. So Dr. Simant Jha, he's the moderator for this session, especially invited moderator. And Dr. Simant Jha is a senior intensive care consultant and a well-known academician is for PSR Hospital, Delhi. Dr. Simant Jha, I just request you to take over the session.
Just before Ajit, just to give my little comment on this session, which is extremely interesting for me. I had this debate, Srikanth, with Dr. Ramakrishnan, N. Ramakrishnan from Chennai. So this was a very heated debate I had once in one of the conferences. So it will be very interesting to see the replay of this debate between my very good friend Srikanth and Dr. Sulagna. So I'm sure it will be a fantastic discussion. Over to you, Dr. Srikanth, and maybe to Dr. Simant Jha to just take over the proceedings. And good luck to both of you.
So I'll invite Dr. Srikanth to talk about the topic he has been given to. So he will be talking in for, so Srikanth, so please start your talk.
Yeah, should I share my screen?
Yeah.
Yeah, just about I'm kind of preparing. I will just try to, is the slide available? I mean, it is visible?
Yes.
Yes.
You have to make it.
I'll just, yeah, just a second.
It is very clearly visible, Srikanth.
Yeah. Let me just make it as a full screen.
Slideshow.
Yeah. So, okay.
Just click on the play button.
Just a second. एक minute. So that somehow that the bar which is at the upstairs.
Yeah, you just click and hold, and you can move the bar. You can move the bar to the bottom.
Okay. Okay, right. Got it. Right. Yeah. Now, I think it's okay. Am I audible also?
Yes, yes, yes.
Yes. So at the outset, I would really like to thank the Bangalore Critical Care Forum and my dear friends, Dr. Ajit and Dr. Pradeep. And let me confess, Dr. Pradeep, I am not as good as the debater you are. And of course, not as knowledgeable you are. I have tried to incorporate a few things which I understood in these 15 minutes. And I will be happy to, to just go ahead in another 15 minutes and talking about pro for evidence-based medicine or EBM as a pure and indisputable science. So, who is this gentleman in this slide? This is myself, Dr. Shrikant Sahasrabudhe. And as of now, if I go to the airport and wants to kind of board the flight, even the security guy at the gate would ask for evidence about my identity. So I have to actually surface him something like this. And before displaying the evidence for who am I cannot enter the airport. The same way, if I have to apply for any institution for my job, I have to obviously kind of submit my degree certificate as well as my certification in critical care if I claim myself as intensivist. What I mean to say that evidence by far at present point in time is very important, if I have to travel or if I have to get the job. How is it placed as far as the medicine is concerned? So I have divided my talk in the form of a little preview on EBM with some historic facts about the EBM. How is it beneficial and advantages of EBM in present day practice, and why should we follow? So talking about EBM, way back in 1996, Professor David Sackett is supposed to be the pioneer and the father of EBM, who proposed the term EBM, and which is based on three important pillars, mainly the individual clinical expertise, the best external evidences, and the patient values, desires, and expectations. So the core of these three circles, as you could see here, is formed by EBM. And by definition, it is a conscientious, explicit, judicious, reasonable use of modern medicine with best of the evidences, which helps to decide about the care of an individual patient. So here we are talking, and each and every word in this particular definition is important and self-explanatory. Now, let us embark on what EBM is in a little more detail. As we know that we are going to practice medicine forever till the time we are alive, and it's a lifelong process to practice the evidence-based medicine, if you really believe in that, which is self-directed, and of course a problem-based learning which happens in EBM. It takes into account the clinically important questions and the informations like the diagnosis, prognosis, treatment, the cost effectiveness, and of course this is for the patient, better patient health care. So it demands a better evidence as compared to a non-evidence-based medicine or a clinical medicine, which actually may not actually demands a better evidence. So we are here in the 21st century, and of course we should probably look for the better evidences for what we do. As was discussed some time back about meta-analysis to be taken with a pinch of salt, I agree with that. But if you see the pyramid of the research, research pyramid, which I will come to shortly, has two basic components which are very important and forms the mainstay of any robust research. that is systemic reviews and meta-analysis. And then there are other components which we will discuss. A bit about history. It got originated in the later half of the 19th century, and we could find some references in the ancient Greece and China. The word EBM was first used by Professor David Eddy somewhere in 1990, and the first time used in medical literature was by Dr. Gayat, who was in McMaster University way back in 1992. What I immensely probably liked about EBM is its pragmatism in the present day scenario. And this is the pyramid, the famous pyramid research which we talk about. And as you go down from the apex to the base, the level of the research values comes down. So you start with randomized controlled blind studies and randomized controlled trials at the apex. And when you come down to cohort studies, the case control studies, the case series, the case reports, the editorials, the personal opinions, the personal ideas, followed by the animal research, and of course the in vitro test tube research. So this spectrum, when you go down, the importance of that particular research comes down. We cannot forget, although that a few of the researches, including the animal research, are important as far as the transplant medicine is concerned. And a study or the format which encompasses primarily the randomized controlled trials and the systemic reviews in the form of meta-analysis, which definitely holds importance when you present a scientific data in the scientific forums. Now coming to the 5A aspect of EBM, and these are the steps of practicing EBM. This is clinically important, so I think we need to discuss this. So it starts with the first A, that is ask a clinically relevant question to start the process of EBM, followed by acquire. So acquiring the evidence will form the second step, and then appraise the evidence, whatever you have with you, and then of course applying the evidence to the particular clinical situation. And the last step would be to assess or to analyze and the adjust outcomes. It has been said that this is one of the first A or the first kind of step of EBM where you use these 5 steps, and it is seen that if you utilize this, it increases the likelihood of a favorable outcome. Now, there is another component of the first A, that is asking the question, in the form of a Pico model, and it has been kind of just highlighted in one of the slides of my earlier colleagues, which is a Pico model, which stands for P for the patient or population, I for interventions, C for comparators, and O for outcome. What does it do? Actually, it helps in structuring the literature search to much better answer which can be located. For an example, if you don't use the Pico, the question which is framed as what is the best treatment for heart failure? But if you actually use the Pico model, the question can be reframed, and which is more meaningful question would be, in an elderly patient with systolic heart failure, do ACE inhibitors reduce mortality in comparison to placebo? So this is where the importance of Pico comes in. Now, what is expected from us as a busy practitioners, professionals, clinicians, intensivists? We are expected to be abreast or updated in the recent, what are the recent advances going on in the globe? Is it possible, and how difficult it is? So if you look at this very simple expectation from a mere general practitioner, is supposed to read about 19 articles per day to get abreast about the recent advances. At the same time, you need to have target reading to issues related to specific patient problems. Mind you, EBM is not a cookbook medicine, and clinicians who fear top-down cookbooks will find the advocates of evidence-based medicine joining them at the barricades. As of now, today, almost all the Western countries' doctors apply EBM, and they get support from their governments, the respective Ministry of Health, and the pharmaceutical industry. So what are we achieving and targeting is to develop a clinical question and search the current databases, which would save time. All of us here would agree to the notion that we do no harm to the patient first, and of course assesses the risk benefit ratio for any intervention we do. We have so many avenues and a lot of websites to surf about what the updates are, but by far the Cochrane library, which has been one of the best to have the current status about EBM across the globe, and this is the website for the same. Now, what are the benefits of EBM? The questions where there are no intuitive answers, the clinical observations, I'm sure everyone will agree, will cause more harm than good. The best example was thalidomide during pregnancy. Use of the best possible evidence for best possible solutions for optimum healthcare. So optimum healthcare, I think here is more important. It actually avoids the major mistakes what we do with the maintaining of high quality standards to save time as well as save patients' lives. It raises our own benchmark. You know, you have to compete with yourself and achieve excellence in day-to-day professional life, which is so very important. It adds up to your satisfaction, it saves your time, and of course, it builds your confidence. At the same time, EBM attempts to find and incorporate interventions that work, not those that should or seem to work. Understanding EBM concepts helps to improve the ability to keep up with the new information and development, and it also allows practitioner to use critical thinking skills like assess, analyze, and apply the evidences. So what are the achievements of EBM so far? It definitely finds a prominent presence in the scientific forums or literature when you talk of anything which is related to the medicine. As I said, Cochrane collaboration is one of the significant development in the history of clinical medicine and has over 400 systematic reviews of clinical trials and the Cochrane library, which I just referred to. It helps us to formulate important guidelines, which I am sure that everyone would take the guideline as one of the important aspect of practicing medicine. It helps in advocacy, and the best example was use of oseltamivir or zanamivir in the swine flu pandemic. It reforms the medical ethics and professionalism. It of course had raised the standard of our practice, and of course the essential component of the medical practice. And what was published in 2007 BMJ as one of the top 15 milestones in the last 160 years of clinical medicine, EBM finds its place. So many supporters of EBM say that using it can address the problems of cost, quality, and assess that bedevil the healthcare system. And if you all agree upon the best practices based on the data and the research, we can actually reduce the unnecessary care, save money, and push people into pathways to yield better results. We can actually use the test characteristics and results to make better diagnosis. We can use evidence from the treatments to help people make better choices once the diagnosis is made. And we can devise research to give us the information we are lacking to improve lives. After all, we the doctors try do no harm and save lives. And when we have enough studies with us, we can look at them together to make a widespread recommendations with more confidence than we would otherwise be able to. There have been landmark papers, landmark trials, and game changers so far in about, say, last two decades of medicine, especially the critical care medicine. And I would like to just enumerate few of them, starting with the lung protective strategies, which had an immense impact on the outcome of ARDS patients in critically ill ICU patients, along with our sedation strategies, which again had a positive impact. The acceptance of mean arterial pressures of about 65, which again had immense impact on the recovery of the patients. The supranormal oxygenation may not be good, and that was the concept which was again put forward by many RCTs, non-usage of colloids in ICU, which also helped us to save our patient. I'm sure everyone knows that intracardiac adrenaline is gone by, and the use of critical care bundles, when we use it in our ICUs, have immensely impacted in a positive fashion to prevent infection and of course to save lives. The blood transfusion strategies which we use of course have also helped immensely to save lives in our busy ICUs. So with this kind of background, we the responsible clinicians or responsible intensivists probably, according to me, have three tasks: is to use the evidence summaries in the clinical practice, develop and update evidence-based guidelines, and of course, enroll your patient in studies, at least try to make some impact in whatever the EBM as of now is there. And let us pledge today that we will move forward from evidence-less medicine to evidence-based medicine. And if I can twist the word, to evidence-based medicine. That's all about it.
Thank you, Dr. Srikanth, for excellent presentation.
Yeah, these are my these are the suggested readings, and these are a couple of references which I used for my presentation today. Thank you.
Also, excellent presentation. Now it all depends on how much evidences you have, because we are going through a big pandemic and we don't have enough evidences. So let us see what Dr. Salguna says, whether to use evidence medicine. And we should not forget, we are living in India and other less developed countries, because whatever data and all, so to follow the protocol and the things in each and at every PSC, then secondary, tertiary centers, it's not that easy. What the Westerns and the US doctors, they are following. So it's a bit difficult. Yeah, you're true. But let us see what Dr. Salguna says. So I'll invite Dr. Salguna for her presentation.
I'll stop sharing my screen.
So welcome, Dr. Salguna.
Dr. Sulagna, please.
Yeah. Can you just a minute? Can you? Am I audible?
Yes. Yes.
Has my screen been shared?
No, not at this point.
Just a minute.
Click on the share screen button.
Yes, I'm clicking, but it is.
What is it coming from?
Actually, system preference telling me to open the system preferences.
Yeah, you will have to enable the Zoom. Just click on enable Zoom to allow the screen share. In the system preference, just click on screen sharing. In the security options, you will have to enable Zoom.
Okay. Can I open another?
Yes.
Just a minute. I'm so sorry.
I think Dr. Sulagna can email the presentation if needs be to Ajit or one of us. We can also play it if there is an issue.
So till the screen sharing starts, so this debate is between evidence-based medicine versus experience-based medicine versus eminence-based medicine, right? Or experience-based versus evidence-based.
Sir, this is basically experience-based medicine, what experience you're having. But you know, evidence-based medicine, what I find, it takes...
Eminence-based medicine is no less.
No less, definitely, sir, but it will take, you know, years, because so many studies, then studies, meta-analysis. But now you are seeing your pandemic, COVID pandemic. You just tell me how many medicines we are having to treat COVID patients. And the evidences are changing all the time, isn't it? Nobody using right now doxycycline. Nobody using right now ivermectin. The WHO has told something for ivermectin, yes. Then we have only steroid. Initially, they were for remdesivir. Then they said no. Then they said yes for remdesivir. Then again, this one IL-6 inhibitor. They initially they said no. Then they said within 24 hours you can use that. So there are so many. How many medicines you are left with? And plasma.
So screen sharing has started.
Oh yeah.
Can I start?
Yes.
I thank all the members of Bangalore Critical Care Association to give me this opportunity. And I also thank my co-debater, Dr. Sahasrabuddha. I'll now proceed with my topic, that is evidence-based medicine is the purest and indisputable science, and I'll discuss the cons of it. Now, as already discussed, the definition over the time has changed from 1992, where intuitive medicine, unsystematic clinical experience, and pathologic rationale were de-emphasized on the ground of evidence from clinical research. This gathered a widespread criticism, and therefore in 1996, David Sackett had to change the definition to conscientious, explicit, and judicious use of current-based evidence in making decisions. Now, evidence-based medicine is formed by 3 pillars, as already has been mentioned, and the 5 questions and the 5 steps which formulate evidence. So, but however, do all the components have equal weightage? No, general priority is still given to clinical research. And how to integrate the components? However, there is no clarity on that. So as there are mainly 2 components of evidence-based medicine, which by the present model. Number 1 is defining, developing medical knowledge, and number 2 is describing clinical practice. Now, medical knowledge can be classified as evidentiary and non-evidentiary. Evidentiary is those gathered from result of clinical experimentation or biological experimentation, like results of clinical research, clinical experience, pathophysiologic rationale. And the non-evidentiary are patient values and preferences, and those from the system features. Now, evidence-based medicine model depends on this hierarchical pyramid of evidence. However, these different qualities, the different areas of medical knowledge vary in quality and not in degree. So therefore, they cannot be ranked in hierarchy. Evidence-based medicine, the practice and the definition of it entails a inherent gap. The gap is of 2 forms, the knowledge-based gap and ethical gap. Now, knowledge-based gap is derived from clinical research because the clinical research is empirical, and the result of the research cannot be directly applied to clinical decision-making in individual patients. Ethical gap, on the other hand, cannot tell us from clinical research results what we should do in a particular situation. We have to consider the values of the patient, profession, and the society. Mark Tonelli, who is one of the strongest critics of evidence-based medicine, says the direct application of knowledge from population-based studies is likely to fulfill the goal of public health. However, the application of same knowledge to the individual patient may be problematic. It can give us an idea of how an average patient behaves or benefits with an intervention. This is the knowledge that can be obtained from a randomized controlled trial. However, the patient at hand is not an average patient, and therefore we need good clinical judgment. Randomized controlled trials have some inherent limitations. The trial subjects are underrepresented because the trials clearly have inclusion and exclusion criteria,
and a minority of the patients with disease are actually included in the trials. It has been seen in one of the reviews of published randomized trials of acute coronary syndrome in USA that only 37%, the patients admitted to the US hospitals with AMI, 37% of them were elderly. However, only 9% were represented in the trials, and the result was similar with women. Randomized controlled trials also do not take into consideration about the long-term therapy. Now, patients get prescription of drugs like beta blockers, aspirin, statin, and ACE inhibitors for years, for decades. But the trial data is only available for 5 to 10 years. Also, these drugs are frequently given in combination, and the polypharmacy is done without any reliable evidence. Development of new therapies like PCI for acute coronary syndromes can change the natural course of the disease. Therefore, continuation of the drugs that were found to be beneficial before the development of these therapies may be questionable in the new era where these therapies have made an outcome. Also, comorbidity is not accounted in most of the trials. Multimorbidity is common in patients with chronic diseases like elderly. Multimorbidity and concurrent drug therapy are often excluded from clinical trials. Now, the treatment effect of a particular drug can have confounding effect on the other multimorbidities and can also lead to a altered clinical outcome. In an association, in a population-based cohort study of 8,500 patients, elderly patients who were followed for more than 24 months with at least 2 of the comorbidities like chronic kidney disease, depression, diabetes, heart failure, hyperlipidemia, hypertension, or thromboembolic disease, atrial fibrillation, it was found that beta blockers, calcium channel blockers, RAS inhibitors, and statins were associated with reduced mortality for the indicated conditions. But warfarin was associated with a reduced risk of death in patients with atrial fibrillation. However, attenuation of the good effect of warfarin was seen in patients who had some combinations of coexistent conditions and received multi-pharmacy. Therefore, for many patients, the application of clinical data remains uncertain from the trials. Now, evidence-based medicine hovers around finding statistical significance. The statistical significance revolves around a dichotomous outcome like p-value less than 0.05 or p-value more than 0.05. This is a very empirical benchmark because p-value does not give a measure of good evidence regarding a model or hypothesis. A single p-value does not mean anything because it is prone to false positives. A p-value when associated with treatment effect or the outcome effect can lead to some meaningful result. It does not say anything about the size and the magnitude of the effect. It can vary with effect size. A large sample size can sometimes lead to a statistically small effect size. The effect size may be small, but it can get statistically significant. A statistical significance may not be clinically or biologically significant. Also, sample size restriction limits meaningful analysis of predefined subgroup in comparison. Results from the Miami trial, where aspirin was given as a primary prophylaxis for patients with cardiovascular diseases, it was seen that there was a significant outcome effect of aspirin in terms of cardiovascular deaths, that is, the results favored aspirin. But when we look into the absolute risk reduction, the number needed to treat was only 6, whereas serious bleeds were caused more in the aspirin group. That was also significant, and that was again, the number needed to treat was 8 by 1,000. So a practitioner may be left in a dilemma that what to give, whether to look for a small outcome effect or to prevent a serious bleed. In one of the landmark trials in intensive care, the Albios Trial, which looked into the use of albumin with crystalloids, there was no benefit in the primary outcome in mortality, 28-day mortality in the albumin versus the crystalloid group. However, when we look into the subgroup analysis, we see the septic shock patients. There was a favorable outcome with albumin with a significant value, but this trial was not powered to look into the septic shock group. Randomized control trials are prone to bias. Bias like the random sequence, like the selection bias in random sequence generation, allocation concealment, performance bias, detection bias, attrition bias, and selective reporting bias. There are also other biases like the funding bias. RCTs are also not pertinent or feasible in rare diseases, in evidence of noxious or toxic agents, like in diseases which are due to smoking or alcoholism, or in toxicology. Evaluation of diagnostic tests can also not be dealt with randomized control trials. Softer parameters like personal preferences, psychological factors, comfort, and reassurance for patients are essential clinicals of humanistic care, but they cannot be accounted for by randomized control trials. Meta-analysis, again, like the randomized control trials, which form the brick of the synthesis of evidence, are again prone to different types of errors. Poor quality of included studies will result in invalid results. Poorly executed meta-analysis. Heterogeneity, that is combining apples and oranges. Heterogeneity can be clinical heterogeneity or statistical heterogeneity. Publication bias is again one of the big problems in our publishing fields. File drawer phenomenon, in which we only look into the published trials and we don't account for the non-published data, which can be representative of the actual population having the disease condition. Publication of positive trials is again favored, and also publication by prominent authors or groups. Now, evidence-based medicine has now, over the last 2 decades, created some adverse effects on clinical medicine. There is bias of objective versus subjective outcome measurement, because tangible outcomes like mortality, efficacy are measured and softer outcomes are not measured. Bias of sponsored research, that is funding bias, because of the vested interest of the pharmaceutical companies for efficacy trials for drugs and devices. In a recent publication of pharmaceutical industry biases on outcomes of clinical trials, it was seen that the company-funded research is more likely to yield positive outcomes, and they are also more likely to be published. Here, the cause of bias is not a poorer methodology, but the biases are introduced through a variety of measures, including the choice of the comparator agents, multiple publication of positive trials, non-publication of negative trials, reinterpreting data submitted to regulatory agencies, discordance between results and conclusion, conflicts of interest leading to positive conclusions, and ghost writings and use of seeding trials. Thus far, the efforts of the research community has been mainly to look into the conflicts of interest, but such subtle evidences of funding bias has to be dealt with. Now, is evidence-based medicine in crisis? The overemphasis on algorithmic rules because of the fear of litigation or because of claiming insurance, the statistically significant benefits with marginal clinical practice may be instituted. Shift is now being seen from diagnosis and treatment to risk assessment in non-disease states. And the shift has now come from the individual patient to disease. So we are now treating disease based on evidence rather than treating the patient based on evidence. In a quality improvement program in USA, which implemented computerized decision support system and also evaluated the medical deviations to the best available evidence, and also conducted a peer review of these deviations, found that 93.6% of the deviations that were recorded were medically appropriate, and only 3.1% were inappropriate. Therefore, this study emphasized that the physician recorded medical exceptions were correct most of the time. Now, what is this staggeringly profitable business of scientific publication? In a 2005 Deutsche Bank report, it referred to this business as a bizarre triple play system in which the state funds most of the research, pays salaries of most of those checking the quality of research, and then buys most of the published products. So it is a triple pay system. The profit margin of the publication houses like Elsevier rivals that of the Google. With a total global revenue of more than 19 billion pounds in 2010, Elsevier scientific publication arm reports a 724 million profit with just over 2 billion revenue, a 36% margin higher than Apple, Google, or Amazon. So this is an industry like no other. Scientists turn slave to the publisher, influencing what the scientists choose to study. In 2008, Dr. Neil Young of the National Institute of Health stated that there should be a moral imperative to reconsider how scientific data are judged and disseminated. Now, COVID-19 has thrown the greatest challenge to evidence-based medicine like no other. The pandemic has revealed all the flaws of our established evidence-based medicine model. We had to experiment with drugs based on biological plausibility without any sound evidence. Trials were many, and many trials were small in size. One of the COVID-19 databases states that more than 40% of the trials had fewer than 100 patients, and therefore these were not of much good quality. And this was a research at unprecedented scale. COVID-19 also demanded publication and the performance of mega trials like the Solidarity, and also incorporation of the adaptive design to the trials. As we see, too many trials of now considered ineffective therapies like hydroxychloroquine, ivermectin, convalescent plasma, lopinavir, ritonavir, tocilizumab have emerged. So from 2019 to 2022, the LitCov trial registry has recorded number of papers of COVID-19 of more than 2.2 lakhs, more than 9,000 systemic reviews, which are mostly of poor quality. 30 systemic reviews were published for convalescent plasma based on only 11 clinical trials, and none of them included all the trials. And there were more than 100 reviews of hydroxychloroquine, and most of this is a wasted duplication of effort. Coming to one of the most debated meta-analysis, in 2021, Paul Marek et al. Published a meta-analysis based on 18 randomized controlled trials of the efficacy of ivermectin in the prophylaxis and treatment of COVID-19, and showed that the ivermectin benefited, it caused significant reductions in mortality, time to clinical recovery, and time to viral clearance, as shown in the forest plot. However, when one of the trials were removed for fraud, it was the data synthesized, the data showed that it was not significant. So this trial, this review actually critically analyzed and did a subgroup meta-analysis of the trials that were included of ivermectin, and the stratification was based on the risk of bias of the and raw data analysis. So it found that the result suggested that the significant effect of ivermectin on survival was dependent largely on poor quality trials. Now, when all the trials were included, the improvement in mortality was significant. When the trials were excluded based on their high risk and some risk of bias, the improvement in mortality was lost. So COVID-19 pandemic has again opened a mosaic of evidence. Use of face mask, social distancing, and hand washing. These interventions, which were deemed to be highly important and were introduced into the policies, were not found from any RCT or any meta-analysis, because these were not feasible or ethical. Researchers have to be pragmatically assess a range of different evidence, surveys, natural experiments, observational studies, and trials, and mosaic them together to give a picture of whether something is worthwhile. Now, one of the interdisciplinary groups, the DELF group, which looks into the viral diseases, published evidence paper on the use of face masks in tackling coronavirus pandemic, drawing evidence from laboratory science, mathematical modeling, and policy studies. However, this evidence was highly criticized by a group of epidemiologists for being non-systematic and for recommending policy action in the absence of quantitative estimate of effect size from robust randomized controlled trials. Now, this looks ridiculous. So time has come so that we evolve from 20th century sense of logic of evidence-based medicine, in which scientists pursue the goals of certainty, predictability, and linear causality, we need to embrace the 21st century epistemology and methods to study how to best cope with uncertainty, unpredictability, and non-linear causality. That is moving from statistical significance and effect size to intervention along with other factors to desirable outcome. Now, COVID-19 pandemic has again given us a new paradigm, that is a paradigm of complex system as compared to evidence-based medicine paradigm. Here, the perspective is on scientific truth, which is multiple and influenced by mode of inquiry and perspective taken rather than any singular, independent, or empirical inquiry. The goals of research will be to explore the tensions. The assumed model of causality will be interacting multilinear. The typical research question should be the combination of influences that can generate a phenomenon rather than what is the effect size of the intervention or the predefined outcome. Here, the approach to data will be not a complete or perfect, but we need to take decisions often based on incomplete or contested data. And the focus of analysis will be dualities. That is, we have to analyze the interrelationships and dynamic tensions rather than dualism like A versus B or X versus Y. So, complementary models of evidence generations can actually make our evidence complete, like observational evidence leading to intervention development, feasibility trials, definitive RCTs, and evidence synthesis leading to policy action, and observational evidence again leading to policy development, policy action, and leading to natural experimentation, evidence synthesis, and this can be executed in the political and the economic context. Now, evidence now also needs to include the real world data, like the databases, which are longitudinal cross-sectional patient chart reviews from electronic hospital health records, patient population surveys, observational cohorts, pragmatic clinical trials, and registries. And with the help of artificial intelligence, we can improve our clinical decision, risk estimation, personalized care, and improved healthcare and system sustainability. So EBM, it is our present, and the future is precision and personalized medicine in the background past of intuitive medicine. Thank you.
Very well presented, Dr. Sulagda. So what the pandemic has taught us that we cannot totally believe evidence-based medicine. We have to see what our personal experiences are also. So I'll invite Dr. Srikanth, what you say, what Dr. Sulagda has talked about.
Yeah, so it was really a very comprehensive, presentation, including the most of the trials which were quoted with their limitations. So I think I would start with the very basic triad of evidence-based medicine, where it definitely takes into account the clinical expertise. So the component which was asked as to how much is the individual component, I think they all have an overlap along with the best evidences which are available, and of course the best the patient desire, and along with the self clinical expertise. So I think we have a very balanced approach here, where the evidence-based medicine takes into account all three components at one time. Talking about pandemic, I think it is very clear that pandemic is not an emergency. It is something which we have the enemy who is unknown. It is bound to happen that we have learning and de-learning of our concepts at a very fast speed. You could see that if as an average duration of RCT or a meta-analysis to get formed and published usually would need about a year or two, and here in terms of pandemic, we saw that the presentations or the RCTs came out within few months and sometimes within few days. So it is definitely the pandemic which posed the challenge, and I don't think we should extrapolate it to the regular RCTs or meta-analysis, which can still hold its place in the evidence-based medicine practice. Having said that, I definitely feel that it has a long history, and it will undoubtedly continue. Since I feel that it gave a powerful impetus and the concept which is quite an explicit element of the medical professionalism. I think gone are the days where we say about anecdotal reports or personal experiences about managing patients, and we have to have very well designed, robust, randomized control trials, which obviously is the responsibility of the person who does it. And of course, I think it is important contributor to the guidelines which we actually see. Evidence-based medicine is the one which will actually is responsible for the guidelines we actually follow. So if we don't have EBM, probably we will not have guidelines where we can follow most of the clinical protocols which we are following today. Obviously, having said that, there are a couple of points which I would like to agree with my colleague on p-value, which definitely has its limitations, where 0.05 may not be taken as the cutoff, and one static p-value will definitely not reflect the statistical significance. At the same time, unfortunate happenings like the industry or the pharmaceutical biases or the influences on the studies, which is the reality. So I think we need to pose ourselves in this midst of the 21st century, having the pandemic just gone over by the crisis. I would definitely stick to my point of that EBM is to stay there, and definitely meta-analysis would be taken with a pinch of salt, but I would definitely not refrain from following the EBM.
So,
what do you want to say? Anything you want to add?
Yeah, me.
Yeah, you want
Yes,
to
sir.
say?
Yes, sir. So definitely, as my topic was, EBM is not the purest and the best of science. So I definitely agree that EBM will stay, and components of the EBM are important for formulating guidelines. But EBM is not the purest and the ultimate science, and it will evolve, and it will evolve to more comprehensive, more pragmatic designs, more adaptive designs, and the guidelines. As if we see the recent surviving sepsis guideline, of the 93 recommendations made, how many are strong recommendations? Only a few. Most of them are weak, low quality evidence, weak, moderate quality evidence. So what does we interpret from those weak evidences? It is that those evidences has to be incorporated in line with the patient preferences and the system preferences. So therefore, there is a gray zone. There is always a gray zone when we formulate guidelines, and we don't know how to apply those guidelines in the individual patients. So this gray zone needs to be bridged by more integrated approaches, which tell us how to integrate a patient value, not on qualitative or not on ordinal scales, but on proper evaluated quantitative scales, how to integrate patient preferences, how to integrate the system logistics, and then only we can see the true picture, not a fragmented picture of evidence of strong hierarchical nature, or not a fragmented picture of unsystematic personal individual expert opinion.
Yeah, so I would like to add here, see, evidence-based medicine is going to stay, definitely. As far as the involvement of the pharmaceutical companies are there, so we have to look for that. And again, personal experiences, physicians' personal experience also matters. But I would like to add that there should be, you have to follow your own national guidelines also. See, suppose you are using injection terlipressin, say 8 mg per day patient can tolerate, but this is for the Western guideline. You might have seen how many patients of India those who are here, they only tolerate 3 mg. Most of them are diarrhea, they're having bradycardia, they're having splenic vasoconstriction. So what I say, evidence-based medicine is good, but you have to follow your own national guidelines also, own regional guidelines, not always because we do CPR. The CPR, they say we have to go to the up to 2 inches when you are pushing your hard and fast. But you see in Indian patients, even up to 1.5 inches, more than 2 inches you go and that hard and fast, you will have broken ribs. So evidence-based medicine is good. It's going to stay. But again, you have to follow your own national guidelines. Pradeep sir, Ajit sir, or anyone else wants to?
Dr. Murali sir,
Shiman,
Pradeep.
Shiman,
Yes,
I want to make one simple point, that in order to practice evidence-based medicine,
Yes,
one
sir.
also needs to have the experience of evidence-based medicine in the same way as one who wants to practice experience-based medicine should have the evidence of experience also. So evidence-based practice of experience-based medicine and experience-based practice of evidence-based medicine proves that they are complementary and not supplementary.
Exactly, yes, sir.
Exactly.
Pradeep, Dr. Murali sir.
Murali sir first, and then maybe I'll talk. Murali sir.
So, Dr. Muralidhar sir.
Can you hear me? Can you hear me?
Yes,
Sir, we can hear.
Excellent discussion, lovely discussion. I'm enjoying it. Please carry on.
Pradeep.
Yeah, so my comments, see, I think we all live in the world of evidence base. So what I see mainly for the benefit of trainees is when we talk about evidence base, we need to take a collective sort of a evidence that is available. So what I see of late is people just pull out one latest article and say, now this has debunked all the evidence that was prevailing over last 10 years. So this is the trend that we have been seeing, even the discussion on colloids or even the discussion on the crystalloids we saw. So I believe that we need to have as Anirban rightly said, we need to have a collective knowledge and a collective sort of a knowledge of all the past evidence that is available to put into the context of the current prevailing evidence or evolving evidence. So that really gives us a cue whether we are interpreting in the light of all the previous available evidence that has been prevailing and that has been available. So that is very important for all the budding intensivists, because very often you would see there is one negative trial, so everyone gets excited, not necessarily taking into cognizance all the work that has happened possibly over the last 10 years, because I think that creates a context, that puts in a context setting for us. Unless we are aware of all the work that has happened, so it's very hard to interpret what has very newly evolved. So the quintessence is to take a collective evidence, then interpret it into the current clinical practices that have evolved, and then make a logical sort of a conclusion. And I completely agree with Sulagna. So there are a lot of pitfalls with the type of evidence that is evolving and the type of statistical jugglery that happens. So it is very, very imperative that we need to take note of what sort of analysis is happening as well to critically appraise. So I think that is where we are at. But as everyone has said, evidence is here to stay. But my only take-home message is take the collective sort of a collation of the evidence that is available to make a logical conclusion, and don't jump on one article that has come, ignoring all the work that may have happened over the last few decades. So that would be my thoughts on this.
Pradeep, to put simply what you have verses said, that in order to practice evidence-based medicine, one needs to look at the base of the evidence, whether the base is friable or is it rigid and strong. So if that requires some experience, and when one does that, probably one can practice the evidence-based medicine in its purest and the best form.
Yeah, absolutely.
No, yeah, and another thing is that obviously the human factor, the human brain influences, I think, the evidence-based medicine as well, because we should be aware of that possibility as well, including the statistical aspect, including the nature of the nature of the evidence, the how it is, how trustworthy is the evidence what we are collecting. There is a human factor, like Dr. Sulagna has mentioned, so many publication bias, so many factors. Some of the some of the positive trials and they are funded by pharmas. So there is a strong there is beyond, the statistical evidence what we are seeing. And even the statistics now that we have the two methods are there, like the frequentist analysis, the Bayesian analysis, and many people, who believe that the Bayesian analysis is just like, you are widening the goalpost just to make it a goal, what I'm.
Yes.
So that kind of a thing is already there. So what I mean is you just cannot say that, it is very much saint and all. Everything is, one good thing about science, everything is disputable. Everything is, we need to, everything is questionable. Everything is disputable. Nothing is pure, actually. Evidence-based medicine also always, you should see with assess with a pinch of salt, see with a pinch of salt, rather than blindly following anything. That's what I just want to say. And some of the evidence, in my opinion, basically we waited for quite long. For example, simple, the proning and all. It took around almost 10 years or something, to the PROCON trial to prove that there is some mortality difference and all. But many people, in their own clinical experience, that time itself, they proved that whenever they prone the patient, the oxygenation improved and all. But, just because there is no evidence, that did not, unfortunately, did not make much of a, that kind of a, publicity was not there, So it, obviously that is there. Obviously, evidence-based medicine takes time for the evidence to build up as well. That is one small thing. But when you believe that something is in front of you, the things are happening, improving. So probably on a case-to-case basis, you may have to, consider. I think it is highly disputable when you talk about evidence. I know that, but even the proning would have helped. My own experience, obviously experience an individual thing does not have available. But still, many people would have felt that obviously when they prone the patient, the oxygenation improved. But evidence took a long time. It's not 2013. We have to wait for the evidence. So it takes a long time for the evidence medicine also to be to be concrete as well.
So I think we should incorporate adaptive designs, and we should have in shelf, this pandemic taught us, we should have in our shelf preconceived research, preconceived trials and preconceived methodologies, which can be surfaced anytime and can be done in a broad manner.
Yes, there was a big impetus to the platform trials. That's because of COVID only.
Yes.
We found large number of platform trials.
Yes.
And today, virtual clinical trial is a reality just because of COVID. And in the coming decade, there will be lots and lots of virtual clinical trials on board.
So another important point, Anirban, Seemant, and Sulagna, although we have tried to use COVID as an analogy for evidence, in fact, the only reason we could vanquish COVID was because of evidence-based that evolved, because we stopped using unnecessary drugs. That itself comes from the evidence and the trials that were conducted. So it is very important how the COVID situation taught us that leaving to the spirit of science can help us conquer any sort of a pandemics or a health threats that would.
Have we really conquered COVID?
No, not to a large degree, yes. To a large degree, yes, because the science has really proven again. Science has really showed again how it can conquer the disease, because I think this was a stellar example, Anirban, how the evidence evolved in a short period of time and we stopped using dangerous drugs and unnecessary drugs. So I would take very strong cues from the COVID pandemic, how science has again thrived to save the humanity. Anirban.
Yeah, I agree. It probably told us what not to do rather than what to do. And I think I would prefer to be roughly correct than to be precisely wrong. So that is the message which I would take.
Shrikant, very well done. So thank you so much to having you here. So it was a pleasure hearing to you. Shrikant.
Thank you, everyone. Wish you a happy Shivratri tomorrow.
Dr. Anirban was on the, I think he was he was in the gym, which I just happened to kind of have an overlook. And the evidence,
yes, it was
evidence of Dr. Anirban in the gym doing the
so that is why I didn't want to miss the experience of evidence from both.
Okay. So
over to you, Ajit.
Yeah. So on behalf of the Bangalore team, we would like to thank all the participants in this CME session, and I would like to thank the moderators, Dr. Seemant Jha, Dr. Ranadhi Chatterjee, Dr. Anirban, Dr. Murali sir, and I would like to thank all the speakers, Dr. Jojo, Dr. Pooja, Dr. Sulagna, Dr. Shrikant, for the excellent presentation. Thank you all. Thank you very much. And special thanks to Microlab team for sponsoring our PROCON debates every month, the monthly PROCON debate. And also many thanks to Hallmark Events for organizing this entire CMB.
And
Thank
just
you
a
all.
small request, Ajit, as we said, we are going to publish these debates in our subsequent journals. So if we could request our speakers to send a transcript of
the we'll do that. I will personally do that. Yes, I will do it. I'll talk. I will communicate with them personally.
We don't want these excellent discussions to go away just this session.
Yes, sir.
It's good to go in a print.
Thank you, sir.
Thank you.
Thank you very much.
Thank you so much. Thank you, everyone.
Thank you all.
Thank you.
Thank you and good night.